There are several ways that Sjogren's brain involvement is described, but not all of them help caregivers understand what to expect next. Today, I am going to walk you through a 5-stage framework for how Sjogren's affects the brain and nervous system, and I will explain how each stage shows up in real life. For those of you who are new here, welcome to this channel. We cover everything you need to know about Sjogren's syndrome, from the symptoms no one warned you about to the neurological complications that most providers still miss. Let us jump on in. If that sentence just landed for you, if something in what I've described so far sounds familiar, I've put together a symptom map that shows exactly how this condition progresses, what shows up at each stage, and where the standard tests are most likely to miss it. It also has a resource you can use to track and organize symptoms before your next appointment. Type symptom map in the comments right now and I'll send it to you directly. Because what I'm about to show you next is why that map matters more than most people realize, and why the stage you're in changes everything about what happens next. One quick clarification before we do. You may hear the neurological side of Sjogren's described using terms like central nervous system involvement, peripheral neuropathy, sensory ganglionopathy, or neurocognitive disorder. These are clinical labels. In real life, though, families and caregivers often just know that something is fundamentally wrong with their person's thinking, their balance, their memory, or their ability to feel their own hands and feet, and they do not yet have the language to describe what they are witnessing. That is exactly what this video is here to help with. So whether you have had a formal diagnosis confirmed, you are still fighting for one, or you are somewhere in the middle trying to make sense of a very confusing symptom picture, stay with me. This is for you. Big picture, Sjogren's neurological involvement is a continuous process. It does not always announce itself clearly or dramatically. It often develops quietly, over months or even years, hiding beneath the more visible hallmark symptoms that everyone focuses on: the dry eyes, the dry mouth, the joint pain, the fatigue. What is happening to the nervous system during all of that time is a separate injury, one that compounds quietly until it can no longer be ignored. These 5 stages are not a checklist. They are orientation points. They help explain why brain fog and nerve symptoms so often go undetected in the early years of Sjogren's. They help explain why caregivers feel blindsided when neurological symptoms suddenly accelerate. And they help explain why caring for someone with Sjogren's brain and nerve involvement often becomes far more demanding than anyone in the medical system prepared you for. Let us start from the very beginning. Stage 1. Subclinical neurological activity. This stage begins before any noticeable symptom appears. And this is the part that surprises caregivers the most. By the time a neurological symptom finally surfaces and gets noticed, the immune system has often already been silently attacking nerve tissue for a significant period of time. There are no outward signs at this stage that you as a caregiver would have noticed. There is nothing on a standard blood panel that would have told your doctor this was coming. And yet, the damage is already beginning. What is happening inside the nervous system during this stage is a complex and layered process. The immune system begins producing abnormal autoantibodies, most notably anti-Rho and anti-La antibodies. You may have seen these on your person's lab results labeled as anti-SSA and anti-SSB. These antibodies are not just markers. Research has confirmed that they are directly implicated in nerve toxicity. They cause dysfunction in the nodal and internodal regions of the axon, which is the long communication fiber of the nerve cell, as well as damage to small nerve fibers. This is not a secondary consequence of Sjogren's. This is the primary immune attack extending beyond the glands and into the nervous system. At the same time, autoreactive T cells and B cells begin infiltrating neural tissues. They trigger chronic inflammatory cascades marked by the release of cytokines, which are essentially chemical alarm signals including interferon gamma and tumor necrosis factor alpha. These inflammatory proteins disrupt nerve function at a cellular level, leading to progressive neuronal degeneration. In some people this process eventually leads to demyelination, which means the protective sheath around the nerve fiber begins to erode, slowing or blocking the nerve signal entirely. Simultaneously, small vessel vasculitis begins creating low-grade ischemic injury, meaning reduced blood flow to brain tissue and peripheral nerves. Research using MRI imaging has shown that people with Sjogren's have significantly more white matter lesions in the brain compared to healthy controls. These lesions, found predominantly in the deep and subcortical white matter, the periventricular region, and the basal ganglia, are markers of this ongoing vascular and inflammatory injury. They can be present even before a person reports any cognitive symptoms at all. None of this shows up on a routine neurological exam. These changes are only detectable through specialized testing including advanced MRI, biomarker panels, autonomic testing, or nerve conduction studies in specialist settings. And in many cases, especially when Sjogren's itself has not yet been diagnosed, even those tests may be read as nonspecific or attributed to something else entirely. What is critically important for caregivers to understand at this stage is the following. Nothing you missed caused this. Nothing you failed to catch early on would have prevented it. The process that is now visible to you was already underway long before it became something you could see. This is not a failure of observation on your part. It is a limitation of where medicine currently stands in detecting autoimmune nerve damage before it becomes symptomatic. If what I just described sounds like the silent years before your person's diagnosis, type the word silent in the comments right now. You are not alone in this, and your community needs to hear from you. Stage 2. Early neurological symptoms. The brain fog phase. This is the stage where many caregivers say things just felt off. They noticed a change in their person but could not pin it down. Their person seemed slower, quieter, more forgetful, more easily overwhelmed. And when they brought it up to family members or even to doctors, they were often dismissed. Told it was stress. Told it was aging. Told it was depression. And they started to second-guess what they were clearly, accurately observing. What they were witnessing are the early neurological symptoms of Sjogren's. Let me walk you through what those actually look like in real life. The first and most universally reported symptom is persistent brain fog. This is not occasional forgetfulness. This is a consistent, daily difficulty with concentrating, organizing tasks, and retrieving words mid-sentence. The affected person may sit down to do something they have done 100 times before, and simply not be able to sequence the steps. They may start a sentence and lose it before they finish it. They may read the same paragraph 3 times and retain nothing. Research confirms that the most common cognitive profile in Sjogren's affects attention, memory retrieval, executive functioning, and information processing speed. One study found that 60% of people with Sjogren's showed measurable cognitive disorders on neuropsychological testing, and that the severity of cognitive impairment correlated significantly with the degree of white matter lesions visible on brain MRI. The second early symptom is mental fatigue, that arrives far faster than physical fatigue. Your person may rest perfectly well at night and still wake up mentally exhausted. They may manage one task in the morning and then be cognitively depleted for the rest of the day. This is not laziness. The brain is working harder than it should have to because the infrastructure of neural communication has already been compromised. The third early symptom is slowed processing. Conversations feel more effortful. Responding to a question takes longer. Following along in a group setting becomes difficult because the person simply cannot keep up with the pace of incoming information. This is sometimes mistaken for hearing loss or inattention, when in fact it is a neurological processing delay. The fourth early symptom is sensory changes in the body. A burning, tingling, or prickling sensation in the hands, feet, or face. Numbness that comes and goes. A crawling feeling under the skin. These are early signs of small fiber neuropathy, which refers to damage to the smallest nerve fibers responsible for pain sensation, temperature regulation, and autonomic signals. Small fiber neuropathy is now recognized as one of the most common neurological complications of Sjogren's, though it is also one of the most frequently missed because it does not show up on standard nerve conduction studies. Specialized testing such as skin biopsy and quantitative sensory testing is required to confirm it. The fifth early symptom comes from the autonomic nervous system, the system that runs the body's automatic functions like heart rate, blood pressure, digestion, and sweating. Research shows that up to 50% of people with Sjogren's show signs of autonomic impairment. In the early stages, this manifests as lightheadedness or dizziness when standing up, which is caused by the nervous system's failure to properly regulate blood pressure changes with posture. It may also appear as digestive irregularity, feeling full quickly, bloating, or unpredictable bowel patterns. These symptoms are often attributed to other causes entirely and are rarely connected to the neurological picture of Sjogren's at this stage. This is also the stage where caregivers begin to question whether what they are seeing is normal aging or something else. If you are asking yourself that question right now, you may already be in this stage. And it is important to know that a full evaluation at this point, including neuropsychological testing, autonomic function studies, and a skin biopsy for small fiber neuropathy, can begin to clarify the picture significantly. Waiting until symptoms become more severe before investigating is unfortunately common, but it is not the right path. If this stage sounds familiar to your experience, type the word foggy in the comments right now. It helps others know they are not imagining what they are watching unfold. And it sends a signal to the algorithm that this conversation matters. Stage 3. Clinically evident neurological involvement. This is the stage where Sjogren's brain and nerve involvement becomes impossible to ignore, because it is now visibly and consistently interfering with daily life. This is also typically the stage at which a formal diagnosis of neurological Sjogren's is finally made, because the symptoms are no longer subtle. They are measurable. They are documentable. And they are disruptive in ways that can no longer be rationalized away. What you will typically see in this stage are the following changes. Repeating questions. Not occasionally repeating something from an hour ago, but asking the same question multiple times within the same conversation, sometimes within the same 10 minutes. This happens because the short-term memory system is no longer reliably encoding new information. Significant difficulty managing tasks that require sequencing or planning. Paying bills becomes overwhelming. Managing a medication schedule becomes impossible without help. Cooking a meal from beginning to end requires supervision. Navigating to a familiar location becomes disorienting even with a phone. These are not signs of carelessness. They are signs of executive dysfunction, which is the brain's reduced capacity to plan, organize, initiate, and complete multi-step tasks. Pronounced word-finding failures. Not occasionally searching for a word, but losing words mid-sentence consistently and frequently. Your person may substitute a vague descriptor like that thing or the place because the specific word simply will not come. They may stop mid-thought and go silent. They may use the wrong word entirely without realizing it. Facial numbness, facial pain, or burning pain across the cheeks, jaw, or forehead. This points to trigeminal nerve involvement, which is one of the most recognized cranial nerve complications of Sjogren's. Research published in studies of Sjogren's-associated neuropathy has consistently identified trigeminal neuropathy as a prominent feature, manifesting as numbness, dysesthesia, or agonizing burning pain in the face and mouth that can be continuous and highly disruptive to daily life. Worsening balance and coordination. Falls that seem unexplained. A staggering gait when fatigued. An inability to walk steadily with eyes closed, which reflects a condition called sensory ataxia. This happens when the dorsal root ganglia, which are clusters of sensory nerve cell bodies in the spinal cord pathway, are attacked by lymphocytic infiltrates. The result is a profound loss of proprioception and vibrative perception, meaning your person can no longer reliably sense where their body is in space without visual confirmation. They may appear clumsy or unsteady and not know why. Mood and personality changes that are striking to those who know the person well. Irritability. Increased anxiety. A withdrawal from social situations they previously enjoyed. A flattening of emotional expression. A loss of initiative and motivation, where the person simply sits and does not engage the way they used to. These changes are neurological in origin. They are not character failings. Research has found that microstructural changes and decreased functional connectivity in brain regions responsible for mood and motivation are directly observable in people with Sjogren's central nervous system involvement. An imbalance in hippocampal function linked to the inflammatory process contributes to depression and slower cognitive function as well. This is also the stage where many caregivers feel deeply invalidated. You notice these changes. You name them. You ask other people in the family if they are seeing the same thing. And often they say no. They tell you that your person seemed fine to them. They tell you that everyone gets forgetful. They tell you that you are overreacting. Trust that instinct, caregiver. You are observing real, progressive neurological changes. You spend more time with this person than anyone else does. Your observations are clinical data. It is time to push for a comprehensive evaluation if one has not already been done, and to document what you are seeing clearly so that it is part of the medical record. If stage 3 sounds like where your person is right now, type the word seen in the comments. Because you deserve to feel seen too. Your vigilance matters. Stage 4. Significant neurological impairment. This is often the most demanding stage for caregivers, because the symptoms multiply and intensify simultaneously. The nervous system is now under sustained immune attack across multiple fronts at once. And the caregiving load expands in ways that are difficult to prepare for, because it is not just the cognitive symptoms anymore. It is pain. It is body systems failing. It is behavioral changes that feel impossible to navigate. And it is a level of need that far exceeds what one person can realistically provide. What increases during this stage are the following. Severe neuropathic pain. This is not the mild tingling of stage 2. At this stage, neuropathic pain can become a central, disabling feature of the person's daily experience. It is described as burning, stabbing, electric shock-like, or deeply aching. It may be constant. It may be worse at night. It may affect the legs, the arms, the torso, or the face simultaneously. For people with sensory ataxic ganglionopathy, the loss of proprioception has now become severe, and even simple movements like walking across a room can feel profoundly disorienting and dangerous. Pain management at this stage typically requires specialist input, and yet many people with Sjogren's reach this stage without an adequate pain management plan in place. Significant confusion about time, place, and recent events. Your person may not remember what day it is with any consistency. They may become disoriented in their own home during periods of fatigue or after disrupted sleep. They may not remember important events that happened recently, including medical appointments, conversations about care, or decisions that were made together. This level of memory impairment begins to overlap with what caregivers associate with dementia-level cognitive decline, and it is essential to understand that Sjogren's can produce a reversible autoimmune dementia in some patients. This is distinct from neurodegenerative dementia, but carries many of the same day-to-day caregiving demands. Worsening autonomic dysfunction. At this stage, the autonomic nervous system's failures become more serious and more difficult to manage. Fainting episodes become more frequent, stemming from orthostatic hypertension and cardiovascular autonomic dysregulation. Heart rate irregularities may be present. Gastroparesis, which is a slowing of stomach emptying, can develop, causing nausea, early satiety, bloating, and malnutrition risk. Urinary retention or incontinence may emerge. The regulation of sweating is disrupted, meaning the person may have episodes of excessive sweating in inappropriate contexts or conversely, no ability to sweat in heat, which creates serious temperature regulation problems. Each of these autonomic failures creates its own caregiving demand on top of everything else. Mobility problems from nerve damage. Muscle weakness may now be present alongside the sensory deficits. Walking may require a cane, a walker, or constant close supervision to prevent falls. The risk of serious fall-related injury at this stage is significant. Peripheral neuropathy affecting motor fibers can cause foot drop, reduced grip strength, or an inability to manage stairs safely without assistance. For people with confirmed central nervous system involvement, this stage may also bring episodes of encephalopathy, which refers to global brain dysfunction presenting as confusion, behavioral changes, or altered consciousness. Seizures are possible in this group, as the inflammatory process within brain tissue creates abnormal electrical activity. Psychiatric symptoms including paranoia, sudden fear, and behavioral changes that appear entirely out of character can emerge from central nervous system inflammation. These are not psychological episodes. They are neurological events arising from an immune-mediated brain injury. A study of Sjogren's-related autoimmune encephalopathy has documented that anti-SSA antibodies in both serum and cerebrospinal fluid confirm central nervous system involvement, and that these presentations can respond to immunotherapy if identified early. Spinal cord involvement is also possible at this stage for some patients. This can range from transverse myelitis, which is an acute inflammation of the spinal cord causing sudden weakness, sensory deficits, and bladder dysfunction, to progressive myelopathy, where motor and sensory function in the legs declines gradually over time. Spinal cord involvement in Sjogren's is one of the more severe neurological complications and significantly changes the caregiving picture. None of these changes are your person choosing difficulty. None of them reflect a personality shift that is permanent or personal. It is a nervous system under relentless immune assault, struggling to regulate basic functions, struggling to communicate reliable signals to the muscles and organs and brain. The behaviors that emerge from this neurological crisis are symptoms, not intentions. It is at this stage that I most consistently see caregivers who are buried under the weight of everything they are carrying. The exhaustion is not just physical. It is the hypervigilance of watching for the next crisis. It is the grief of losing the person you knew piece by piece. It is the guilt every time you reach your limit and snap, even though any human being would reach their limit under this level of sustained pressure. It is the isolation of a caregiving experience that most people around you cannot understand because they are not living it every day. This stage is not something to manage alone. Support is not optional here. It is a medical necessity for your well-being as much as it is for theirs. If this is the stage you are in right now, type the word heavy in the comments. Someone else needs to see those words appear and know that another caregiver understands exactly what they are carrying. Stage 5. Severe neurological disease. In the most advanced stage of Sjogren's neurological involvement, multiple body systems are severely compromised simultaneously, and care shifts from management to protection and comfort. Communication becomes profoundly difficult. In patients with advanced central nervous system involvement, language disruption can include aphasia, which is the partial or complete loss of the ability to produce or understand spoken language. Even when frank aphasia is not present, cognitive decline, severe fatigue, and motor difficulties may combine to make meaningful conversation rare and exhausting for the person you are caring for. Do not mistake reduced verbal output for reduced awareness. Many people at this stage are still taking in far more than they can express. Total assistance becomes necessary for daily activities. Bathing, dressing, grooming, and eating all require caregiver involvement. As neuropathy progresses to affect the muscles controlling swallowing, dysphagia develops. This means the person has difficulty swallowing safely, increasing the risk of aspiration, which is when food or liquid enters the airway rather than the esophagus. Aspiration pneumonia is one of the most serious and life-threatening complications at this stage. Careful attention to meal texture, positioning during eating, and close monitoring for choking are essential safety considerations. Severe autonomic failure at this stage can affect heart rate regulation, blood pressure stability, and respiratory function. The body's ability to self-regulate its most basic processes has been significantly undermined by years of immune-mediated nerve damage. This creates serious medical fragility. Small infections, episodes of dehydration, or disrupted sleep can trigger rapid decompensation in ways that would not occur in a healthier nervous system. Falls become a critical safety issue. The combination of sensory ataxia, muscle weakness, autonomic blood pressure dysregulation, and cognitive impairment creates a high-fall-risk environment that requires environmental modification and near-constant supervision to manage safely. In patients with the most advanced central nervous system involvement, the risk of stroke from ongoing cerebral vasculitis, as well as the risk of recurrent systemic infection, creates a medical picture that requires close coordination with a multidisciplinary team including neurology, rheumatology, palliative care, and infectious disease specialists. What is important to say clearly here is that not every person with Sjogren's reaches this stage. The trajectory of neurological Sjogren's is highly variable. Some people plateau at stage 2 or 3 for years with appropriate immunotherapy and careful management of their systemic inflammation. Others progress more rapidly. The point is not to create fear. The point is to make sure that if you are in this stage, or approaching it, you are not trying to navigate it without adequate support, guidance, and medical backup. At this stage, care becomes protective and comfort-focused. Many caregivers report feeling numb by this point, and I want you to hear this clearly. That numbness is not a character flaw. It is your nervous system doing what it must to help you survive the magnitude of what you have been living through. It is not detachment. It is protection. And it is a signal that you need, and deserve, significant support of your own. If you or someone you love has reached this stage, type the word brave in the comments. Because that is exactly what you are. Both of you. I get asked this question constantly, and the truth is there is no single answer. Life expectancy and progression speed following Sjogren's neurological diagnosis vary enormously from person to person. Some people experience mild neurological symptoms that stabilize and never significantly worsen, particularly when systemic disease activity is well controlled with immunotherapy. Others move through the stages more rapidly, especially those with confirmed central nervous system involvement, untreated systemic inflammation, uncontrolled vascular risk factors such as high blood pressure or diabetes, chronic poor sleep, repeated infections, or significant chronic stress. Research has documented that the presence of anti-Ro and anti-La antibodies correlates with more extensive central nervous system disease, and a higher likelihood of focal neurological complications including ischemic brain lesions. It has also been shown that neurological symptoms often precede the Sjogren's diagnosis itself, sometimes by years. One study found that in patients with Sjogren's-associated neuropathy, 93% were diagnosed with the underlying disease only after neuropathic symptoms had already appeared. This tells us something important. The neurological system can be the first place Sjogren's announces itself, even before the sicker symptoms that doctors typically look for. So if you are someone who has been managing unexplained neurological symptoms for years and only recently received a Sjogren's diagnosis, it is likely that the immune-mediated nerve damage began long before anyone connected the dots. That is not a failure of your care team alone. It is a systemic gap in how Sjogren's is screened and recognized. And it is why this channel exists. What matters for you as a caregiver going forward is not the average timeline. What matters is watching for change, documenting it carefully, communicating it clearly to the medical team, and advocating persistently for the level of specialist input that your person's neurological picture actually requires. Rheumatology alone is rarely sufficient at the later stages. Neurology, neuropsychology, pain management, and palliative care coordination all have a role to play. These 5 stages are not a prediction of your exact journey. I want you to think of this framework the way I described it at the beginning. As a map, not a countdown. The staging model helps you orient yourself, identify what stage you may be in, and anticipate what might come next so that you are not caught completely off guard. It is not a sentence. It is a tool. Sjogren's neurological involvement is one of the most under-recognized and under-researched areas of autoimmune disease. That means you will likely encounter providers who minimize what you are witnessing. You will encounter documentation that does not fully capture what is happening. You will encounter a staging model that leaves you feeling like your person's experience does not quite fit any neat description. And you will encounter well-meaning people in your life who do not understand why this is so hard, because from the outside, Sjogren's does not always look like what people imagine when they think of a serious neurological disease. If that is where you are, caregiver, you are not alone. This is the moment to seek additional specialist support, to request a second opinion from a neurologist who has experience with autoimmune nervous system disease, to find a community of caregivers who understand your specific situation, and to get additional training and guidance so that you feel less like you are improvising your way through an impossible situation.